the community paramedicine kind of world that we're going into, and I think that this is one of the things that as a region we should be very strong to own pre-hospital responses by paramedics and make sure that it is in the purview of the EMS physicians and the EMS agencies. I think that if we don't take control of this, we don't stand up for believing that community paramedicine falls under the realm of pre-hospital care, there is a strong possibility that other parts of medicine will try to own it, for lack of a better descriptor. Anyways, any discussion?
No, I guess the only thing I think you do have to put the type of agency it has to be under, whether it's a pre-existing ambulance service or an ALS first response unit, because there's no provision to have anybody respond. Even actually ALS first response aren't in the law as emergency vehicles or response vehicles. That's usually done on a town or whatever level to get that emergency
ALS first response is part of Article 30.
Right, but they left it out in the vehicle and traffic law. They don't exist. I've been trying to straighten that out with one of my state senators for quite a while.
Right.
Something about the provision of the vehicle being state certified.
I mean, the agency has to
Well,
be an
again,
ambulance.
we're just
Right.
talking about the staffing standards, we're not talking about the agency.
But
We're just talking about who would have to go to a non-transporting response for an advanced life
I'm not
support
talking about
unit.
on an ambulance, I'm talking about some kind of flight.
Whether it's an emergency service vehicle, which is defined by the state, whether it is on an ambulance, whatever the vehicle modality that you choose to use, right now, we're just trying to talk about the staffing standards for that type of response.
But the legal entity must be an ALS ambulance service.
Or an ALS first response service.
Okay, deal.
Well, that's where I was a little confused, because we have in the city volunteer ALS responders, first responders, right, who are solo medics.
They're not, actually. They need to have a backup EMT at a minimum responding.
So would that be the same here? In other
No,
words,
it wouldn't.
This is like an ALS flight.
If it, so, meaning the current standards, the current staffing model, a paramedic who is responding as a first responder needs to have a EMT at a minimum backing him up to respond to that
So
call.
we're gonna change it so that they don't need to have the EMT.
Correct.
Except if they're in an ambulance, then they can't do it, because there you need the provision to transport, which requires.
Well, again, we're just talking about non-transport.
Correct, correct, so just as long as it's clear out.
Again, I think that we're moving into a new part of pre-hospital care, and I think it's really important that we take these steps towards driving this forward.
Can you give like an example where you'd see this being used?
Sure.
We'd like me to-
Well, Kevin is gonna, Kevin's right here, so.
We are currently responding in an ambulance with 2 providers for community paramedicine responses. Now, I say community paramedicine, but just to be clear, we do everything by Article 30 and by our New York City REMAC protocols. So we're not creating a new standard. But what we've noticed is that we have only 5 transports out of the initial 36 and 0 out of the recent 7 responses that we've done. So essentially, we think that it would be, there isn't a lot of value add coming from that other partner. And these cases are already sort of coming to us outside the 911 system, right? So somebody's decided that they don't need 911. And so the ALS provider who arrives on scene can then request transport if necessary.
You know what, I would beg to differ after what happened this week. To have the second body for safety, if nothing else, I see a value added in that, having a partner. So that's something you might want to consider also before you start pulling people away from, having
One second, one at a time. Let him finish speaking.
Because you don't know what situation you're sending that one paramedic into, okay? And that's something, when you think of this, you're absolutely right. One paramedic could probably do it, but operationally, to keep that paramedic safe and have the EMT to be the extra set of hands, I don't think we'd be so quick to get rid of that EMT.
Just by program design, these are already pre-selected patients. These are essentially enrolled patients for these specific programs. So they're going in, these are patients who have been cleared through social work and case management. These are typically the frail elderly, homebound, bedbound types of patients who have their acute exacerbations. And I mean, there are organizations out there with now several thousand calls under their belt, but with similar results to what Kevin is describing. And without this, like I said, these are already predetermined patients. It's no different than a guy delivering a pizza, from a safety standpoint.
And from a safety standpoint, how many people, the delivery guys get mugged? So, I mean, that's the only thing I would say, you know, caution, go with this caution. Because again, especially after what happened this week, and I said this many years ago after 9/11, we want our people coming home the same way as they went to work in the morning, and that's what I would consider this. I'll shut up.
Yeah, and just a clarification, how's the call generated? It's because it's not in the 911 system.
Correct.
So it's no different than, I mean, you know, I don't want to minimize it, but like visiting nurses that
Right, home
surgeons
care.
that they go and they have a preset
Right.
list of patients that they're going to go see,
So-
and suddenly the lady calls, listen, I'm, you know, not feeling well,
So
and
just to be clear, these are unscheduled visits, but they're done through a response system, essentially. So they're not 911 calls, they're not emergencies, but they are unscheduled. So I'm having a little bit more shortness of breath than I normally do. I'm gonna call my doctor's office. My doctor's office sends a community paramedic to the house who's gonna operate still within the regional protocols. We do not have regional community paramedic protocols yet, but they're gonna operate within the protocols and make a determination if, in conjunction with the doctor, this patient needs to stay or go.
Can I make a suggestion that you send out a survey to the proprietary ambulances and find out how many, just going on the non-emergency, like you're saying, calls, how many issues they have? That might be an interesting way to get some data on what the threat level is.
Sure.
Just have an idea, because it doesn't mean the little old lady won't start swinging their oxygen tank at you or something, you know?
I'll take my
Exactly.
chances. I like my chances, I like my chances. All right, Jeff.
So, just, I don't wanna belabor this, I don't
All
wanna
right,
belabor the
guys,
point,
come on.
but, you know, as you said, they're unscheduled visits, but they're not unscreened patients.
Correct.
These are patients that are enrolled in a program for this, that are known to the people who are sending to help. Listen, there's no such thing as a totally safe scene, we all know that, right? But as far as from a risk standpoint, it's not a totally unknown, like, you know, a regular EMS call. There is some relationship with this individual to the entity that's providing the care.
Correct. Dave.
I would recommend making the wording indicating that this is a minimum staffing standard, so that you don't discourage people who want to have that extra partner on scene for safety.
100%. Just 1 second. The REMAC standards are set by definition as minimum staffing standards. That's the title of the
Just,
document.
I mean, to allay fears, I mean, these are very structured calls. These are driven by protocol, much more, you know, in terms of the entry criteria, the identification of these patients. And there are certain calls that will automatically result in a dual response. Anybody with a fall, just because one person can't lift up somebody who's fallen from a safety standpoint. So these are calls that have already been vetted through the clinical call center, probably 15, 20 minutes even before the ambulance or the provider has been dispatched.
Yes.
So the concept we're looking at is trying to convert the community paramedics similar to the visiting nurse service system, right? Where the visiting nurse is a single nurse.
Yes.
And those are vetted calls as well, for the most part. They're scheduled for 4, 5, 6, whatever.
I would say that the only difference, and this is a very important difference, is a scheduled visit with a visiting nurse versus an unscheduled visit with an emergency medical response person.
And that single paramedic on scene, once they get into the door, can do more. Right, currently on an ambulance, in the 911 system, you have to have 2 paramedics to do your full complement of what you can do.
Correct.
The single paramedic in this environment, not being in the 911 service and not in a transport unit, could that person run a code while they're waiting for another medic to assist?
Volunteers now only have to have 1 paramedic.
But they also have an
They also have
EMT.
an EMT.
Right, but in this case, they wouldn't have.
But there's also, but it's
Right.
also the
I'm just saying, one second, hold.
EMD process that identifies these patients, all right, in terms of what their clinical status is, their access to medical records.
Right,
These
but
are pre-prescribed
Glenn makes a very interesting point with regards to, you know, patients present one way on the telephone and they can present a different way in the home.
Having trouble
That's-
breathing, they code when you get there.
Yeah, I mean, that's
I put on
a
the sick
very,
leave rest, yeah.
one at a time, one at a time. That's a very valid point. I think that what
I think the chance of that is gonna be lower.
Right, I think
because
that's-
it's screened by,
if you're vetting these cases appropriately and these are cases in your system, I mean, Kevin, you wanted to say something?
Well, yeah, I was just quickly gonna say that, if any member of service comes upon a patient in any setting, they can always call for more resources. So again, this patient would be required, in the language change, to have previous established relationships with other entities. And certainly in my program, I can't speak for other programs, of course, there's new criteria by which they're gonna abandon sort of any kind of CP modality and start acting as close to 911 as possible.
Correct,
But
yeah.
not less than 911. But that's not the
Yes.
This is different than home visiting nurses, right? Where this is chronic condition, wound care, other stuff, right? These are scheduled visits, right? There's an acute component. Yes, they're being screened, but again, these are acute problems. To just send a single provider
One second.
may not really be adequate. I mean, we should get some more data and, present it first before even,
I got you.
going further with this.
Mike?
There are multiple publications out there. I mean, this is about entry criteria, frail, homebound elderly, most of these are enrolled patients who have made their wishes clear as to what they would like. And I can tell you that for those who have made their wishes clear, it's not to go back to the hospitals and to manage their acute or subacute process at home. And so it's been, the literature is out there, and the body of literature is growing. This is not for the 911 community. These are pre-selected patients who have truly made their wishes clear. And this is essentially a
I
role
think
model.
that when you're talking about scheduled or unscheduled visits, you're talking about the equivalent of having an appointment at your doctor's office versus calling up and seeing your doctor in an acute fashion because, you have a cold that day. That's the type of patients we're talking about. Now, you're right that the cold could end up being something more. Could be pneumonia, could be whatever it is. But I don't know if the EMT that is standing there next to the paramedic or that responds with the paramedic there's not a lot of value added to that one person. I mean, that's what the staffing standard is now. It doesn't say that they have to be there, it just says they have to be responding. So theoretically, a paramedic could be on scene, there could be an EMT responding. Is that paramedic supposed to just stand there and wait until somebody else gets there? Probably not. They probably should begin treatment. I don't know if the person is adding a lot of value just in the fact that they're responding.
Well, I mean, to serve to assist, the paramedic and manage
Right, but
the patient.
let's say they're 10
They're not
minutes
just
away.
standing there, they're assisting.
Well, they don't necessarily have to be there. According to the staffing standard, they just have to be on the way. So if they're on the way, they're 5 minutes away, the paramedic is still going to start doing the care that they're supposed to render. And if they feel that it needs to be a transport, they're going to upgrade that call or downgrade that call, whatever it might be. Again, I think that this is where medicine is going. Let's be realistic. That's the horizon and that's the future. And I think that we need to start doing it in a way that we're going to maintain a good enough quality of care in the pre-hospital setting, understanding where medicine is headed. I think if we don't, then we're going to end up with people doing it outside of the scope of what we're doing and probably without the same controls that we want to put in place.
True, if you could send what data you have around would be good. The other thing is, you're also not having to worry just about the patient, if you have an irate family member too. So again, it's a situation, even in schedule, there's always there's an unpredictability when you're in their space, in their home.
Understood.
Just to play devil's advocate, because I do generally think that this is, we need to accommodate community paramedicine. I think this is something that we don't need to be the last region in the country to embrace. But just playing devil's advocate, I would point out that a lot of the data that we have so far involves medics who are specifically chosen, who are pre-selected, and then receive advanced training. And that's not really built into this.
So I would just suggest that is in a system where a community paramedic is doing skills beyond what we consider the scope of our practice right now. They're specifically trained to do advanced assessments and advanced skills. We're not at that point yet. I agree, we have to go there, and I think that we, as the leaders of pre-hospital care in the region, should be striving to develop community paramedicine protocols and training and kind of build that level of care in our region, but we're not there yet.
I just to clarify,
Hold on, I just want to see whose
advanced
hand,
assessment is
hold
not
on,
advanced skills,
hold on one
that
second.
requires-
So, again, I just want to see whose hands are up. I'm going to take these last comments and then we're going to adjourn. Paul, and then you did,
I think what's been discussed here is important. I do think the ownership and the getting us up to speed with the rest of the nation is important. But I think we're missing the boat here. I think we've been trying to shoehorn community paramedicine into an existing language where we have protocols for a CFR, protocols for BLS, protocols for CFR, protocol for ALS, protocols for each facility. I think that this is one of these situations where a separate set of language and a separate set of documents should accompany this type of medicine, because it is different from what we do, and I think we all feel that. We all know it's sort of there, it's not there, it is under Article 30, and we should own it, Joe. I completely agree, but I think even when it comes down to the medical control physician component, it's not the same EMS care that we did 5 years ago. And to move forward appropriately is to have a separate set of documents regarding community paramedicine.
So I think that's true. I think we should put together a tag to develop community paramedicine protocols for our region. Thank you.
I think it's a huge benefit for patients, but something that is a visiting nurse on the side, and does on-call visiting nursing, like you pointed out, it's not the patient that you worry about, it's the area and the family and the house that you're going into. And I can tell you that as a visiting nurse, when I take an on-call patient, if it's geographically deemed a high crime area, I'm actually set with an escort.
Right.
So it's just something to keep in the back of your mind. I think it's a very beneficial program, it just has to be done very carefully.
And that's a very reasonable standpoint. Again, the idea here is not to make anybody unsafe or to remove a resource that's needed in a particular situation. It's to take the situation that doesn't need that resource and make it more manageable. You did, and then...
I just want to say that there are, and I agree with this, there are several volunteer systems across New York City right now that dispatch paramedics and BLS from their home location, not together, and sometimes the medic gets on the scene first, and the BLS one is delayed by 3, 4, 5 minutes, and sometimes the BLS one gets first. And if it's in a high crime area, like he points out, the dispatcher tells the units, wait downstairs until your partner comes and go up together. So common sense has to be used. But it's quite often, I mean, I personally have gotten to the scene and there's nobody else there but me, and I'm stuck running the code until I call out and get me many more backups, and within 2, 3 minutes people come. But it's not unheard of to come there alone and have to deal with it. You just do.
We're going to finish with Mike, and Marie wants to say something.
ALS first response is actually being done by single providers all over the state of New York, separate from community paramedicine. So just before we lose sort of that vision, all over New York State, they're the first one through the door, separate from
100% agree, but our regional protocols right now do not allow for that. So we should change our protocols to allow for that, and I would agree with you. I think that Paul's idea is a great one. If anybody's interested in participating in a tag to start developing regional community paramedic protocols, see me after the meeting. I think that's a great idea. And we're going to finish with Marie, and then we will adjourn, unless there's more new business.
You know, it's been a really bad week. We had a murder of one of our EMTs, and there's been an outpouring from the EMS community to support her, that's Yajira Arroyo and her family, across the sectors. I was communicating with the fire department because we had many ambulance agencies that wanted to participate in the procession, and I was really disappointed today. We were told that they would not be allowed to participate. I just wanted to bring that up. That's it.
Motion to adjourn.
Motion to adjourn.
Second. Good. Thank you very much, everybody.